Hello, this is Jeanne E. Poole. Welcome to the March 2024 HRO2 podcast. The first paper in the lineup this month is the third paper in our series of articles highlighting the early contributions to electrophysiology from global regions and countries. This paper comes from Dr. Iturralde, summarizing the contributions from electrophysiologists in Mexico. We thank the authors for their contribution. The next paper is titled Left Bundle Branch Pacing versus Ventricular Septal Pacing for Cardiac Resynchronization Therapy by Drs. Jeanne E. and colleagues. In this retrospective analysis, the authors examine echocardiographic outcomes of left bundle branch pacing, left ventricular septal pacing, and deep septal pacing in heart failure patients. Left bundle branch area pacing is defined as capture of the subendocardial area of the left side of the interventricular septum with or without left bundle branch capture. Left ventricular septal pacing was defined as unipolar tip pacing with a right bundle branch block morphology in lead V1 and absence of left bundle branch capture. The deep septal pacing was defined as the inability to penetrate the septum to reach the LV subendocardium without a right bundle branch block pattern. The 91 patients were at 5 Mayo Clinic centers, with 52 receiving left bundle branch pacing, 25 patients who had left ventricular septal pacing, and 14 patients with deep septal pacing. The lead used was the Medtronic Select Secure 3830 pacing lead in all patients. Procedural outcome measurements included the procedure time, fluoroscopy time, the distance of the lead to the tricuspid valve annulus, which was measured at 30 degrees RIO projection. Pacing thresholds, R-wave amplitudes, and lead impedances were measured at the end of the procedure. Patients returned for in-person follow-up in the device clinic at 3 months and subsequently by remote monitoring every 3 months, where R-wave amplitude, pacing thresholds, and lead impedances were measured. Transthoracic echocardiographic parameters were collected from baseline and follow-up, including left ventricular ejection fraction, left ventricular end systolic diameter, left ventricular end diastolic diameter, and response to CRT, which was defined as an absolute increase of greater than 5% in the left ventricular ejection fraction after 3 months. Clinical outcomes included time to first heart failure hospitalization and survival. The authors identified that 91 consecutive patients with HF-rep underwent and attempted left bundle branch pacing. This was achieved in 57.1% of the patients. Left ventricular septal pacing was achieved in 27.5% of patients, and deep septal pacing in 15.4% of patients. The QRS duration was narrowest in the left bundle branch pacing group at 134 milliseconds compared to left ventricular septal pacing, which was 141 milliseconds, and in the DSP group was 151 milliseconds. The baseline characteristics of the 91 patients was 74 years of age, 33% female, left ventricular ejection fraction of 26%. QRS morphology was similar across the groups. The LVEF was lower in the LVSP group than in the others. The median follow-up duration was 307 days. 40% of patients had CRT defibrillator therapy, 22% had CRT pacemaker therapy, and the remaining 39% had single or dual chamber pacemakers. At a median follow-up of 307 days, the LVEF improved substantially in the left bundle branch pacing group and in the left ventricular septal pacing group. In the first group, left bundle branch pacing group, the EF improved from 36 to 47%, and in the left ventricular septal pacing from 33 to 42%. The primary outcome measures compared LVSP and DSP to LVBP. The all-cause mortality hazard ratio for LVSP was 1.07 and was 7.83 for deep septal pacing, and the difference across the groups was significant. The lead depths were similar between left bundle branch pacing and left ventricular septal pacing, whereas the DSP depth was less than 6.7 millimeters. The lead distance from annulus, the procedure duration, and the fluoroscopy time were similar across the 3 groups. Pacing thresholds at implantation and follow-up were stable in all 3 groups. Sensing amplitudes were higher in the left bundle branch pacing group over time, and the impedance decreased in the left bundle branch pacing and left ventricular septal pacing groups. Importantly, there was no significant increase in left ventricular ejection fraction in the DSP group. The LBBP and LVSP groups had a significant decrease in left ventricular end systolic dimension and a significant decrease in left ventricular end diastolic dimension, whereas the left ventricular end systolic dimension and left ventricular end diastolic dimension did not change significantly in the DSP group. A multivariate analysis was performed for CRT response. It was found that a unipolar tip paced right bundle branch block morphology in lead V1 during the procedure predicted better CRT response with an adjusted odds ratio of 14 and a significant p-value. The rate of heart failure hospitalization was comparable between the LBBP and LVSP groups, 9.1 versus 16.3%. That was not a significant difference. Heart failure hospitalization was 31% in patients with DSP, which was a significant difference compared with those with left bundle branch pacing, with a hazard ratio of 5.1 and a p-value of 0.33. Deaths from any cause occurred in 2.1% of patients in the left bundle branch pacing group, 4.2% of patients in the left ventricular septal pacing group, and 38.6% of patients in the deep septal pacing group, which was a significant difference. The authors conclude that in patients undergoing conduction system pacing for CRT, that the target should be for left bundle branch pacing. Left ventricular septal pacing had comparable cardiac resynchronization outcomes in this study compared with left bundle branch pacing, and therefore can be considered as an acceptable procedure endpoint. The authors recognize that larger and prospective studies are required to support these observations. The next paper is titled Trends in the 30-Year Span of Non-Infectious Cardiovascular Implantable Electronic Device Complications in Olmsted County by Dr. Kalgi and colleagues. The purpose of this study was to describe trends in non-infectious CIED complications over the past 3 decades in Olmsted County. Using the Rochester Epidemiology Project, comprising records of over 500,000 residents of Olmsted County from 1966 to the present, the database was searched for CIED implantations between 1988 and 2018. ICD-9 and ICD-10 codes were used to determine device upgrades from permanent pacemaker to ICD or a CRT, or ICD to CRT using transvenous leads. Device extractions with transvenous lead implant at the same procedure were also included. Complications were identified by chart review. The Charlson Comorbidity Index, or CCI, was calculated for all patients at the time of the CIED implantation. Complications included those that were managed conservatively or requiring an intervention. Complications included perforation, hematoma, pneumothorax, and lead dislodgement. Major complications were defined as any that required repeat procedural intervention. The authors identified 2,536 patients, 76% who had had a pacemaker, and the mean age was 74, with 42% women. 157, or 6.2%, had a device-related complication. A total of 2.7% of the implants had major complications requiring intervention. Lead dislodgement was the most common, occurring in 2.8%, followed by hematomas occurring in 1.7%. The rate of complications increased from 1988 to 2005 and then decreased, mostly due to a decline in hematomas. Complications occurred more frequently in patients with prosthetic valves. Interestingly, few patients with complications had obesity or diabetes. Hematomas were more common in patients with cardiomyopathy, prosthetic valves, and strokes, whereas patients with pneumothoraces were more common in women and older age. The authors conclude that their study presents a real-world trend of CIED complications over 3 decades. They noted that lead dislodgements and hematomas were the most common complications. Importantly, complications have declined over the last decade. The next paper's title is Outcomes with Guideline-Directed Medical Therapy and Cardiac Implantable Electronic Device Therapies for Patients with Heart Failure with Reduced Ejection Fraction. This paper is by Dr. Mignoni and colleagues. The background to this study is that the legacy ICD-CRT studies were conducted prior to contemporary heart failure medical therapy, which may limit the generalizability of those trials to contemporary heart failure patients, and opens the question regarding the benefit of these devices. The purpose of this study, therefore, was to evaluate survival outcomes associated with GDMT in patients with or without an ICD or CRTD and left ventricular ejection fraction equal to or less than 35%. This is a retrospective observational study using de-identified data from the IGNITE database between January 1, 2016 to December 19, 2023, and included patients from 24 U.S. institutions. The IGNITE database is derived from the CardioCare platform, which is a digital health platform that is used by participating institutions across the United States. The authors identified 43,591 patients with heart failure who had a prescription history for at least 1 year prior to time zero or index. The patients were then evaluated as to how many GDMT medications they were taking and whether they had had an ICD or CRT implanted at 24 months of follow-up. The mean age at index was 71 years and 34% of the patients were female. At 24 months, the authors found that 99.1% of the patients had been prescribed 1 GDMT, 89.9% 2 GDMT, 54.8% had 3 GDMT medications prescribed, and 17.2% had 4 GDMT medications prescribed. 15.7% of the total population had an ICD or CRT-D placement. Amongst the remainder who did not have a device at 24 months, 45% had an LVEF greater than 35%. Survival rates were derived for patients who received a device or did not receive a device according to the number of GDMT drugs. In the patients without a device, 54% were prescribed at least 3 GDMT medications. The estimated 24-month survival rate was 64% with 0 GDMT, 67% with 1 GDMT, 72% with 2, 77% with 3, and 82% with 4 GDMT medications prescribed. In the patients with a device, the majority of patients had at least 2 GDMT medications. 77% of the patients had at least 3 GDMT medications. 79% had 2 GDMTs, 80% had 3, and 84% had been prescribed 4 GDMT medications. A multivariate analysis was performed with adjustment for patient age, sex, and comorbidities. The authors identified that GDMT was associated with a lower mortality risk compared with no GDMT, with a trend toward lower mortality risk with each additional GDMT class prescribed. Importantly, ICD and CRT-D therapy was further independently associated with lower mortality risk in this population. The authors conclude that the present study observed that both higher counts of GDMT classes prescribed and device therapy with GDMT were found to be associated with greater survival. Further study is needed to prospectively assess the outcomes with specific contemporary GDMT regimens and ICD-CRT-D therapy for heart failure with reduced ejection fraction. The next paper is titled Predictive Utility of the Impedance Drop on AF Recurrence Using Digital Interprocedural Data Linked to the Electronic Health Record Data by Drs. Paul Copeland and colleagues. The purpose of this study was to look at local impedance drop during AF catheter ablation and to evaluate if it predicts 1-year atrial fibrillation recurrence. Additionally, the authors examined if there was an impedance drop threshold that was most predictive. The study included patients from the Mercy healthcare system who had AF and an AF catheter ablation. The data were derived from CardioNet and the electronic medical record. The outcome measure was a composite 1-year outcome of repeat ablation, AF rehospitalization, direct current cardioversion, or initiation of a new antiarrhythmic drug post the blanking period. Logistic regression was conducted and adjusted for demographics, clinical, and ablation characteristics. A total of 242 patients were included in this analysis. 23.6% experienced the composite endpoint at 1 year. Patients in the lower third versus the upper third of the average impedance drop had a 5.9-fold higher risk of recurrence, which was 37 versus 12.5%. The threshold of 7.2 ohm impedance drop was the best predictor of AF recurrence, with a sensitivity of 0.73 and positive predictive value of 0.33. Patients with an impedance drop of 7.2 ohms or less had a 3.5-fold higher risk of recurrence than patients with an impedance drop greater than 7.2 ohms. Adverse events were similar between the two groups. The authors conclude that average impedance drop is a strong predictor of clinical success in reducing AF recurrence, but as a single criteria for predicting recurrence only reached 73% sensitivity and 33% positive predictive value. The next paper is a methods paper. It is titled Safety of Sports for Patients with Subcutaneous Implantable Cardioverter Defibrillator, or Sports SICD, Study Rationale and Protocol by Dr. Ehud Koren and colleagues. The background of this study is to identify whether or not the recommendations for competitive athletes based upon the experience with transvenous ICDs holds true for the SICD also. As noted by the authors, the inappropriate shock rates for the subcutaneous ICD have become nearly as low as for transvenous devices. The authors have planned a multi-center observational study designed to collect data on the safety of sports activities in patients with implanted SICD systems. The study is named the Sports ICD Study, which stands for Sports for Patients with Subcutaneous Implantable Cardioverter Defibrillator. 450 patients will undergo baseline assessment, including indication for the subQ ICD, arrhythmic history, subcutaneous ICD data and programming, and data regarding sports activities. Patients will be all enrolled in the Boston Scientific Latitude Home Monitoring System. The authors posit that the results of this study will aid in shaping clinical decision-making, and if the tested hypothesis can be proven, it will allow for safe continuation of sports for patients with an implanted subcutaneous ICD. Well, we look forward to the results of this important study. The next paper is a Topics in Review paper. It is titled, What Do National Radiotherapy Guidelines for Patients with Cardiac Devices Teach Us? This is by Dr. Andre Mircea and colleagues. This is a very nice paper that reviews the current guidelines and expert consensus documents regarding CIED risk when patients undergo radiation therapy. They discuss potential adverse effects, a proposed mechanism for the possible adverse effects, and propose an algorithm to help determine risk in individual patients. The next paper is a case presentation. The title is Zero Fluoroscopy Transeptal Puncture Guided by Right Atrial Dense Precision Mapping by Dr. Jeanne E and colleagues. The case is about a 65-year-old patient who presented with atrial fibrillation. The 12-lead electrocardiogram showed rapid ventricular response. The echocardiogram documented a normal AV diameter and cardiac function. Atrial thrombosis was excluded with transesophageal echocardiography. And after discussion with the patient, the authors decided to perform RF ablation as the treatment method and the zero fluoroscopy technique. The authors then describe and summarize the outcome of this interesting case. The final paper is a research letter. The title is Ultrasound-Guided Explantation Technique for Implantable Lubricord in Patients with High Body Mass Index, a Practical Approach. This is by Drs. Chokanand and colleagues. The key findings are, first, that existing guidelines recommend explantation of an implantable lubricorder either upon battery depletion or reaching a diagnosis, taking into account patient preferences. Second, they note that implantable lubricorder localization through palpation may be unreliable in individuals with high body mass index, often necessitating the use of fluoroscopy. Third, they identified that ultrasound-guided ILR explantation is a highly efficient and radiation-free technique that provides real-time device localization and minimizes incision size with the potential to improve patient care. Well, this ends the March 2024 HRO2 podcast. As always, I am thankful to all the authors for submitting your papers to HRO2 and for all of you who listen to the podcast. I look forward to sharing next month's papers with you in the April podcast.